Essentially, everything we think we understand about health insurance is false. So I reacted very quickly and easily and simply said, don't worry about it, leave them out of it, I'll pay for it. And I was told I couldn't. You're not going to make me take a pill instead of getting my knee replaced.
Disclaimer. The information provided in this video is for educational and informational purposes only, and is based on personal experiences and research. It is not intended to provide legal, medical, or financial advice. Viewers are encouraged to consult with qualified professionals regarding their specific circumstances. The opinions expressed in this video are solely those of the creator and do not represent any organization or institution. Always verify claims and information independently before taking action. Alrighty, Frank. So, just to get this started, we'll get a little bit of background information on you, who you are, work experience, career, and then we'll get into the nitty-gritty of today's episode, okay?
Mm-hmm.
All right. Go ahead whenever you're ready.
Well, I'm Frank Lobb. I'm a retired Navy pilot, retired general manager in the Dupont organization, consulted across the country on the Clean Air Act. And while I'm not an attorney, I've been around the law a long time and got exposed to the healthcare system and came up with some knowledge that just isn't out there. And it's knowledge that would help a lot of people if they fully understood what's wrong with the healthcare system. In other words, so much of what we understand within healthcare is wrong. Essentially, everything we think we understand about health insurance is false. And I just felt that having that knowledge, I had to share it. So I've done my best to put it out there. I'm not selling books, although the book is what's brought me here because there's been a change in the market that we'll talk about. And I think it's very significant, particularly for individuals with insurance and for those who are sending bills, because it just changes the entire billing structure dramatically. So for the most part, I'd like to share that information. I've done it through a book. We have a website. Well, the book is The Big Lie in My Healthcare Bill. And the website we have is killabill.com, as simple as you come.
Yep, killabill.com.
Killabill.com.
Fantastic. And I was looking at killabill.com too before getting on here. I did a little bit of background research, and I saw you had your about what really got you here, as far as like your personal story, aside from the U.S. Navy retired pilot, Dupont, the clean air with the EPA. It was a personal thing with a wife, correct? That kind of led you down this long road.
It's kind of ancient history in some place. I've been remarried and I've done very well in life, and life moved on. But years ago, and it also speaks to the healthcare industry because it hasn't changed since 1990, which is about when I had my issue. And I had a wife that had a very serious health problem, nearly died, was able to bring her back from death's doorstep, and the doctor said she needed additional help, additional care, and the insurance company said they wouldn't cover it. So I reacted very quickly and easily and simply said, don't worry about it, leave them out of it, I'll pay for it. And I was told I couldn't. And I tried 3 other hospitals, and as soon as they realized that my insurance company was denying coverage, they refused to provide the care. And she died, never getting that care. So I took the insurance company to court, not because they didn't pay, but because they wouldn't let me pay. And we danced around in the court through 3 courts for the better part of certainly 8 years, you could say 10 years, depending on how you look at it. And while I was denied ever a fair hearing, I will say, in that system, what I was able to do was get a very, very close look at their internal documents. I read the contracts, which you just can't get access to. And they're not, fortunately, it wasn't just in Pennsylvania and it wasn't just in my home state. I read all the contracts and they're the same. And again, one of the best things, at least in this particular instance, I had a background in contracts.
Yeah.
So I knew what I was reading. And it was exactly the opposite of what I was being told. But I did understand for the first time how they deny coverage and care at the same time. So that's what brings me here largely, a better understanding of what we are actually owed in the way of care, uh, coverage, and billing. And that's the basis of the book.
Okay.
I'll add one other thing, and that is, I'm not sure I would have written it because I've tried before, and up until this point, pretty much felt like I was fighting a losing battle. Nobody really wanted to hear it. But in the past year, the Consumer Financial Protection Bureau got uh, concerned about the bankruptcies, the out of control healthcare bills, the problems within the healthcare industry. And so they weighed in and they said that we have a right to ask for the accuracy of a healthcare bill.
Mm-hmm.
Now, that may seem pretty simple, like, sure, haven't we always had that? And what I need to tell you is, no, we have not. You could ask for the accuracy of any bill in the country and you would get it, but not a healthcare bill. The courts, in fact, have routinely argued that we only have the right to get the name of who's sending the bill.
So that'd be the provider or the insurer.
Typically, the law has favored ruling on collection. And so uh, they basically run you out of gas because by the time the bill gets sent to collection, in 30 days, the courts view the bill as accurate unless you've properly refuted it. And nobody knows how to do that. It's not difficult, but people don't know how to do it and make phone calls instead of a written letter. And so the 30-day calendar is running, and it gets kind of vague in the laws whether it applies to the bill itself or the bill in collection. But by the time that 30 days expires, the bill has already been determined to be accurate, and you have no right to determine or to ask for proof of accuracy. The CFPB has changed all that. They've said not only do we have that right, but they've advised us for each healthcare bill that we should ask for it. And when you marry that request and that right with a thing called the Fair Debt Collection Practices Act, which has been around for many years, uh, if you ask the right questions and you do it in writing within the 30 days, the billing, whoever's billing you, is stuck because they can't give you the accuracy due to the fact that the contracts that I talked about, these secret contracts that I've read and so forth, are identical across the country. And they say that that data cannot be shared. In other words, the CFPB is saying we have a right to it in order to enforce the bill or before the bill can be enforced. And yet the secret contracts say that data can't be given. And
So
the only
that's a
caveat,
conflict right there.
I'm sorry,
So that's a bit of a conflict right there that,
it's huge.
yeah, like I want to know what my bill is, and I have a right to know what my bill is. And then the contract that I'm assuming it's between the hospitals and the hospitals and the
CFPB,
insurers, the CFPB, they're saying in their own contracts that you can't share that information with the consumer.
they cannot share the pricing. And you see, because you don't, there's a thing called the charge master, and I'm sure you're aware of it. Oh, those are the retail prices. The insurance company have contracted prices,
Yeah.
and they're at the back end of these provider agreements. Well, that data has been ruled by the states and so forth as confidential and proprietary material. So under state law of every state, it cannot be shared, and they're in sealed libraries across the country, and they may be identical, not in terms of pricing, but in terms of terms and conditions. But what you need in order to demonstrate, what you want to see in order to demonstrate accuracy, is a listing of those prices for the services that you received.
Yeah, listing of the consumptions, right? So if I, for example, let's say I used two normal saline bags in my care, and then I got 10 gauze sponges for wound care or something small. You'd want to have that accurately reflected in the bill, and if it's not accurately reflected, then you can't be charged for it, right?
Yes.
Okay.
And if you don't get that proof of accuracy, and if we went to the supermarket and got a basket full of groceries for your Thanksgiving dinner, you'd expect to see a printout with all the prices for the various items, and at the end of it, a total that made sense to the listing of prices, right? Well, that's
What
all you're
one would
asking
call
for a
a
healthcare bill.
receipt.
Yeah,
Yeah.
but you can't get that on a healthcare bill, and you never have seen one. All it says is, this is the bill, this is the reduction from insurance, you owe the rest.
Yeah.
All the details missing. Now it's missing in a world where 70 the healthcare industry uses 77,000 different billing codes
And they don't teach doctors those, and doctors are the ones that generally have to put those billing codes in initially. Like it's
initially.
like the ICD-9 codes. Like this is what you're here for in the hospital, this is what you're here for in the provider, and we're going to type this in and it's going to cover this umbrella of costs. But it doesn't break down what those costs are, does it?
No. And the insurance companies tend to bundle things or unbundle things depending upon how they can reduce what they're paying.
Hmm.
And so there's a conflict between generally the provider, a big provider, and the insurance company as to what the right code should be or are, and that turns into dollars, big dollars. I just pull something. This whole thing is characterized by the U.S. Consumer Financial Protection Bureau, the CFPB, stating that healthcare is rife with error. 80 the yeah, Decker's Hospital Review: 80% of all medical bills contain error. Uh, Medical billing errors are common and costly. NBC Chicago: the cost of healthcare billing mistakes is a staggering $68 billion a year. Kaiser Health Research: medical debt has become the leading cause of bankruptcy in the U.S., the Associated Press. I could go on and on with quotes like that. It's a huge problem. And it stems really from the fact that the insurance companies can pretty much pay whatever they want or as little as they want contractually.
Yeah.
And then what is the hospital going to do with what hasn't been paid? When you check into most hospitals, they will tell you that you owe whatever your insurance doesn't pay, which is in direct conflict with what's in their provider agreement. It's just like in Medicare. If you have Medicare, um, the only way you can be charged if you get the care, the only way you can be charged for that care, even if Medicare denies coverage, is if you signed a separate ABN, advanced billing notice, right?
Saying
Because
I
most
agree
of
to
the
pay this in the event that my insurer does not pay.
yes, but you can only be asked to sign that for a specific procedure. You have to get alternative pricing, alternative procedures. It's never done.
Yeah.
It may be done routinely. I've certainly seen it, but I've never had a case where I said this is inappropriate and they didn't yank it back as fast as they could. Because in general, the reason that a Medicare bill is rejected or declined is because the billing's wrong, the coding's wrong, the numbers are wrong. There's an error in the billing, and so the thinking is, why should the patient pay for an error that the hospital made or the doctor made?
Yeah.
Can't be billed. And I recently had a $3,000 bill uh, that fit this world exactly. I paid it with a credit card, came out, contested the bill, and the surgical unit didn't even try to defend it.
They just dropped it.
They just dropped the $3,000 bill. Matter of fact, how much funny it is, I've gotten several requests to come back. I even got a birthday card celebrating my birthday. I'm not exaggerating. I got a
So come
birthday
on back,
card from these.
Frank.
I showed these people $3,000 and I got a birthday card from them
Yeah.
because they cannot afford to contest it
Yeah.
because their contracts state specifically, either Medicare or private, that they can't bill me.
Hmm. I've also seen something along the lines of when a something doesn't get paid for. Like let's say that there's a charge that the insurance did not pay and the patient wasn't able to pay, they can just write that off as a loss at their net, on their net, what's it called? At the end of tax time, their reports for the year, they can just write that off as a loss basically, and then not be taxed for it. That takes off of their actual tax money they have to pay back.
I'm sure it's that way. There's
I mean, it's
also
an operating cost at that point.
there's also a wrinkle in there somewhere where where they fail to get paid, they write it off as a contribution so they can avoid
Loopholes.
the tax. I've never went into that with any detail other than the fact, no, they do it. But there's some heavy games played. And while, uh, let's say come at it the other way, I don't think anybody can prove the large healthcare facilities in the country are anything but flush with cash.
Oh, they absolutely are.
They're doing very, very well.
Yeah, I mean, look at the magnificent hospitals they're building in different cities across the country.
The atriums,
Yeah,
glass in all directions.
Atriums, Banner, IU. Look at the massive structures that they're building. They're building super hospitals in Texas. They've got these
Yeah,
massive 17-story tall hospitals
absolutely.
pumping through hundreds of thousands of patients a year.
But again, they're very smart people. You've got attorneys and accountants that separate the money. And
Yeah,
if you look at their endowment funds and you look at their incomes, you should be managing or merging them somehow because it's all their money.
yeah,
Um, as far as taxes go, they limit what they have to pay taxes by segregating the money. But back to the point, one of the things that um, I would like to say stress here is that if you go back to how all this started, you don't have to have any real bad actors in it. I mean, it's easy to do at this stage because what's going on is so wrong. But it's like walking out on thin ice, the way I describe it. Each step isn't so bad, but as you get further and further from the shore, you can't afford to turn around and go back.
hmm
And if you look at health insurance, it all started back around in the 30s, back around the Depression. And people got all the care that they needed for a small monthly payment. And that held all the way up into about the 1990s,
hmm
where the cost of healthcare, at least from a perception standpoint in Congress, got out of control. And there was a rumor, or at least a belief, that the doctors were overprescribing and that this care had to be reined in and so forth. And that responsibility of reining in care was, in a sense, assigned to the insurance industry, which at that time was pretty much simply HMOs,
hmm
which fit the model that I'm talking about, all the care you need for a simple monthly payment.
Yeah.
Um, but if you look at, and that system ran into some serious trouble, not just Congress. Uh,
There we
okay.
go. We're good. We're back to recording.
uh, it's easy to find fault with the people that run health insurance and there are people in the healthcare business. I think it's a mistake. You really need to look at how we got to where we're at, and
Okay.
then be honest about where we are. Um, what I would say is that insurance started back in the 30s, and when people got all the health care they need for a small monthly payment. And that worked very well up until something like around 1990. And the system had expanded so rapidly, the costs were going up, Congress was upset, and they began to look at the insurance industry to rein in the cost of healthcare. They were concerned that doctors were overprescribing, and it got to be a bit of a mess. And then there were a bunch of bankruptcies uh, that really upset the industry. And to make a long story short, things changed. The simple part of that whole experience was that there was only one form of insurance, essentially the HMO.
hmm
And there was a big HMO backlash that was in the middle of all that turmoil. But the insurance commissioners of the country sat down and tried to come up with a format to how they could make the system go forward really with more control. And because of the backlash, there was also a Supreme Court ruling that said that it was a unanimous ruling in 1990 that the rationing of health care was the point of private health insurance.
To ration.
So, yeah. So, I mean, so the rationing of care back there was pretty obvious. But how are they going to do that? Because only your doctor, that's my doctor and your doctor, can determine the care that's needed.
Mm-hmm.
The contract said we got all that was needed. So they couldn't do it by rationing care without being outside the law.
Yeah.
And besides, if they just simply limited the coverage, that wouldn't do it either, because as I said earlier in my example, I had every intention of paying for the care and then going back after it.
Yeah.
Once my wife was taken care of. And I was 100% confident I'd win that fight, because only my doctor could determine what was necessary. Insurance has no right to limit it.
Yeah. Insurance shouldn't have a medical degree. They can't
That's right.
say you don't need this
And a
kind of care for
license,
this condition.
and a little thing called a license
Yeah.
they don't have. But these are smart people. And what they came up with was just not limiting coverage, but limiting all payment. So if you read these contracts that really came out of the National Association of Insurance Commissioners, the reason they're so identical across the country is because they were written by this national organization and then given to the states to adopt.
Okay.
If you look at them, there's a few words different, because attorneys always do that. They have to put their word on it,
But
their
largely
spin on it, but they haven't changed the structure. And the structure is what counts here. And if you look at them, they in about 5 different places state the following. You get all the care, you as an enrollee in one of these plans, get all the care you need that your doctor says you need. And the insurance company then gets the right to decide whether it wants to pay for it. And if they decide not to pay for it, then the patient is not to be billed. And I can show you time and time again where this has been stated and followed. So you really have a situation where they're not just denying coverage, they're denying all payment when they decide to limit care.
Yeah.
And in a sense, you could get kind of, you could look at it a little differently and say, well, they don't really limit care. What they're doing is they're forcing the doctor and the hospital to limit care.
Yeah.
Okay. But again, if you look at it closely in the law, they're so linked through contract, they're the same. Okay. What's wrong here is they're trying to have it both ways. They want us to believe that because it's insurance, we owe whatever isn't paid. And at the same time, they want the right to deny us the care.
Yeah. So
You
that
can't
no
have
one even
both
gets
sides of that. You can't have both sides of that argument and be legal,
Yeah.
being under the law. Now, what's so different now? Why have I written a book, and why are you and I talking? The Consumer Financial Protection Bureau has found that the problem with health insurance bills is so big that they needed to do something. They called it a food fight between the big providers and the insurance industry,
Yeah.
with the patients caught in the middle. And they said we have a right to determine, to have the accuracy of a bill proven. I think I said earlier that the estimates are that 80% of the bills are in error.
Yeah. You said that to the tune of like $63 billion a year, billion with the B.
B, with a big B.
The big B is how much you get overcharged, and you can't even prove the accuracy of the bills.
And we need to remember that big B is coming out of our pocket.
Yeah.
That's not a
It's not coming out of
government
the
expense.
insurers. It's not coming out of the hospitals. Not
No,
coming out of the pharmacies.
no, that's us.
It's coming from the people that are also struggling to put food on the table.
That's right. Well, there's a long-standing piece of law, federal law, that says that if you request reasonable proof of accuracy of a bill, it has to be provided. And if it's not provided, the bill can't be enforced. So if you write that little letter and simply refer to the actions of the Consumer Financial Protection Bureau, CFPB, and mention the requirements of the Consumer Financial, I'm sorry, the Fair Debt Collection Practices Act, you effectively stop a healthcare bill dead in its tracks. Not because you're skipping out on a bill, but because you're simply forcing the healthcare insurance industry and the big providers to live up to the terms of their own contracts.
Yeah.
So you take somebody like me who's been burned badly, lost somebody that was dear to us, uh, and now knows exactly what's in these contracts and exactly how they misstate them and abuse them. And at least I feel a moral obligation to stand up and say something.
Yeah.
Do nothing more than to say, hey, look, this is what's really in your health insurance. It's not insurance. Okay. It's not your doctor, because your doctors are actually a subcontractor of the insurance industry as long as you're in network. Okay. You don't have any ownership of this. You think it's your plan? No, it's not. It belongs to either your employer, or even if you buy it directly, you're just a member in the insurance company's plan.
Yeah.
So you run down the list, and it it's a fraud. Attorneys don't like the word because you have to prove intent. And I've always said, if you look at the way they've done it and you have to prove intent, it ought to be a slam dunk,
Yeah.
because nobody could have gone to these many hoops, through these many hoops, and not intended to do exactly what they've done. And matter of fact, if you look at some of the statements where they say you owe whatever your insurance doesn't pay, it's very clear in just the choice of wordings that a very clever attorney wrote it so he could claim both that it's insurance and it's not insurance
Yeah.
in, in
All in
order to reduce the
the same
cost.
one paragraph.
Yes. Yeah, they intended. By the way, one other thing, let me point out that really uh, is a real bonus for the insurance industry and why they love it. Every year, we own a business and we have 50 employees. So every year we get an insurance or a broker in here, and he lays out the coming year's plans, 7 or 8 changes from what we had last year.
Hmm.
And I defy anybody to be able to reasonably understand the changes.
Yeah.
It's 80 here percent of this and 60% now and 7 back and forth. Uh, and how does this happen? I mean, how can they change plans so readily? And the underlying benefit of this fraud in the system is because the insurance company doesn't have to pay anything anytime. They can routinely say, oh, we did 80% last year, we're only going to do 70% this year, and not change a contract any place. Okay.
Just what they say that they'll pay.
Yeah, because these little brochures aren't contracts.
No.
Little brochures are nothing more than a brochure.
Yeah, it's a little infomercial for your eyes.
That's right. And I sat in on a presentation on Medicare Advantage a week ago, and I was quiet through most of it, which I gave myself some credit for because I was ready to jump up and down a couple of times. But
Because you know
anyway,
what you're
finally
talking about, and the instinct to just be like, "Oh, I can raise my hand right now and just destroy
yeah,
this argument."
I thought I'd been polite long enough, and I finally put my hand up and I said, "Excuse me, I got a couple of questions here. You keep calling this Medicare. It's clearly not Medicare. It's private insurance that the government buys for you.
Hmm.
And you keep talking about the benefits of the coverage. Well, wait a minute. Under Medicare, the coverage is guaranteed by law, just like a payment in Social Security.
Yeah.
Over here in Medicare Advantage, it's really the same plan that I get from my employer, and I'm not guaranteed anything. I have no right to coverage. They just may give it to me, but I have no right to receive it, nor can I enforce that right.
Yeah.
And surprisingly, the guy he said, well, you're right on that, but we have some other advantages.
Oh
and
my
I
goodness. See,
and I had to laugh because that's what I thought insurance was about, to protect me when I really need it.
yeah, I mean, life insurance, you've got car insurance, is to protect you when accidents happen for your life or when you get into a vehicle accident with someone else that's also insured. Fault comes back and it covers you, so you're not legally liable. And it seems like health insurance as a product right now is not giving you that same coverage.
Well, it isn't. It's because it's not insurance. It's a plan.
It's a plan. Okay.
But they want you to think of it as insurance because then you naturally assume that you owe whatever isn't paid. But that's not true.
Okay.
And hey, look, the insurance industry can, I mean, I've been around a long time. I'm an old man, and I have advanced
Don't get
this a
hard though.
number of times. And until the CFPB made their change, until they got in the game, I was just kind of whistling in the wind. But at this point, they sure know who I am. And if they want to dispute it, hey, come talk to me.
Mhm.
I've talked to a lot of attorneys and I haven't lost a fight yet. Not a fight, but a discussion among them because it's black letter law. If
Mhm.
you get into this contracts, the terms and conditions are so clear, they're just not arguable. And so they do not want to argue with me, or they won't or haven't. And I invite them. Hey, if I'm wrong, tell me.
Mhm.
But I haven't had anybody step forward. That's for sure.
Probably 'cause I don't want to lose.
All you're really doing is making them adhere to their own terms and conditions.
Well, yeah, they want to prove a point, but as soon as you read back the terms of the contract that they gave you to sign and you say, hey, this is where you said A, B, C, and D, and it immediately voids whatever they were saying.
Exactly. And it's, uh, I mean, just to show you how much they've twisted the system into a pretzel, one of the clauses in these terms is a provision that came from the National Association of Insurance Commissioners, supposedly for insolvency provisions. Because back around 1990, there were a bunch of big uh, insolvencies, bankruptcies. One of the largest was a company known as MaxiCare.
Hmm.
And the insurance industry sort of just backed away and then allowed the providers to go bill the enrollees or the patients. Well, the insurance commissioner said that's not really fair. I mean, the people had insurance. It's not their fair fault the insurance company went bankrupt. There should be a provision that would prevent the providers from billing the patients. So they enacted it, and it's called the enrollee hold harmless clause, or just the hold harmless clause.
Okay.
And it says that you cannot, well, the insurance company has a right not to bill, or I'm sorry, to pay. So, and if the insurance company does not pay for whatever reason, not for insolvency, bankruptcy, but for whatever reason, you can't bill the patient.
That makes sense.
Yes. But if you ask a state what that means, that simple language means, they will tell you that only applies in case of insolvency. However, what they're doing is they're playing a game with you. Under under Supreme Court ruling, a state is able to claim whatever it wants is the meaning of language that it writes for enforcement purposes, for its own state enforcement.
And so that does
However,
vary state to state. If you go from Indiana to Pennsylvania, it could be enforced differently.
no, what I'm saying is the state has a right to interpret its own language whenever it enforces that language.
Okay.
Okay. But that doesn't apply here. They don't bother mentioning that this is in a contract between two private individuals or two private entities. Contract law applies. And
Hmm.
under contract law, it's a four corners, as they say, definition. And since insolvency is nowhere to be found in this provision, and the provision says any failure to pay for whatever reason, it can only mean exactly that. So it's not limited in the contract at all. It's for all payment. And the states are just avoiding it because if they acknowledge what I've just said, the system collapses because, again, they can't bill you. And think when I
So
was, go ahead.
I was gonna say, so it seems like obviously politics and stability of a system is at play here for certain state to state.
Oh, certainly. The by far the largest lobbying group in the country is the healthcare industry.
Absolutely. Leaps
And
and
it's
bounds.
not even close. I mean, we think of the Defense Department and so forth and all that is spending a lot of money to lobby Congress and their pet programs. They don't
Mhm.
come close to what the healthcare industry spends.
Pharmaceuticals, hospitals, insurance agencies,
I'm going to
private
be
holding
so
firms.
yeah. I mean, it's billions, and it's the I made the mistake of thinking one of the large conservative organizations, and I'll avoid using the name. Anyway, one of the large conservative organizations would certainly take the field when they realized that you couldn't pay for your own health care, because that was the issue that upset me initially. I can't even pay for my own care. They've taken away my right to pay for health care.
Yeah. Even if you want to pay out of pocket, you're
If I
not
want to
able
pay out
to.
of pocket, as I did, I couldn't do it. So I thought, boy, if I just share this with them, they'll jump all over it. Oh, was I ever wrong? Because what I didn't know until later was that healthcare, I'm sorry, that conservative entity got most of its money for operations from the healthcare industry.
From some sort of political action committee, I'm sure that
Yeah,
had billions of dollars
they
behind it.
they they are primarily funded by the healthcare industry. And when I wrote my first book, I got this really nice letter from this entity saying what a great book I had written and so forth and so on, acknowledge about everything I'd written, and then asked me to help uh, join them or to join them in helping people understand that this is really insurance and they really owe. And I went back and I said, no,
No,
you can't do that. That's the reverse of what I put in the book. And they would never pick up the phone again.
of course, because you kind of showed that you weren't willing to roll over and play ball.
I could show you a very nice warm letter about what a great job I had done from their president. And then they would never pick up the phone, talk to me. They would never answer a letter. They would never answer an email. Boy, they shut me down like hell. And it's what we've done. And I want to be careful not to just blame everybody in the insurance industry or whatever. Uh, it's just that we've gotten to the point where the system has gotten so bad and there are so many people getting hurt. We really need to get honest with ourselves and look at what these systems really are.
Hmm.
The way I describe it, the care, the coverage, and the billing restrictions are still there as they were many years ago. We just have to be smart enough to know it
Hmm.
and then be our own advocate, because the healthcare system is becoming more and more complex and we're getting caught in the bind. We're getting hurt.
It's becoming more efficient.
Yeah, mathematically efficient. I deal with
Yeah.
that a little bit. I mean, there's only one way you can look at this. I'm an engineer by training, and I really would love to deal with some of the politicians that talk about, or at least discuss with the politicians that talk about efficiency. Efficiency is simply the dollars spent over what you get, right?
Yeah. Return on
Okay.
investment, right?
So we know the cost is going up. What we think of as far too fast. Mathematically, the only way I can increase efficiency is to reduce what I get faster than the cost is going up.
Yeah.
How many of the people in the United States are going to buy into getting less health care in order to satisfy the calculation of efficiency?
Well, if they understood what the repercussions of that would be for them and their family's healthcare, they probably wouldn't buy into the system the way it's going now.
We're saying the same thing, just different way. There's just no way you could sell that to the American people.
No.
Efficiency sounds great, but when you look at the math, what they're really telling you is they want to give you less.
Yeah.
Doctor in the United States used to have 800 patients. Today they want them to have 3,000.
Mm.
There's no way a doctor can know 3,000 patients.
No.
It's impossible. Okay. It takes 3 weeks to see a doctor.
Hmm.
The doctor today, my old doctor, took care of all the health care I needed. It was a personal relationship.
Yeah.
Okay. If I needed to go to the hospital, he put me in the hospital and he followed me into the hospital. Today's doctor, family doctor, is a PCP, primary care physician.
Yep.
He is only to keep me from getting sick and then treat only the most minor ailments. If I have to go to the hospital, he has no admission privileges. He can't put me in the hospital.
They can only recommend that you go.
And then you have to go through the emergency room, which 10 years ago they said, oh, we don't want to do that. But
And
that's
now
what you
that's
do
the
today.
primary way.
The best you can do is your doctor tell you to go sit in line in the emergency room and hope that double they take you in. And the emergency room, and this blew my mind when I wrote the book because I never would have guessed it. You would probably recognize the term. Treat them and street them.
Yeah.
Treat them and street them. I would love to have the healthcare industry talk about that term because I've never used it that I didn't get recognition from the hospital or the nurses and the doctors exactly what it means and how prevalent it is.
Yes. Although in the last few years, with new generational terminology, it's went from treat 'em and street 'em to treat 'em and yeet 'em. Because we say yeet when we throw things out. That's kind of the way that it's gone, and it's pretty apparent across the country that's the way it goes.
But I'm an engineer, and so I think in terms of systems and I'm an old guy, so I think of analog systems.
Mhm.
In the old system, because your doctor put you in, he followed you in, and there was a direct responsibility for what happened in the hospital and your doctor. Doesn't exist anymore
Yeah.
because you have to go through the emergency room. There is no single doctor that handles your case.
Yeah. You can talk to two or three different providers down in the emergency department before you even get admitted.
Okay? And I had a very good friend who I advised needed to be in the hospital, went to one of the best hospitals in this area, and he was out in a couple of days. And I saw him and I said, well, what did they find wrong? And he said, they didn't really say. They told me to see the doctor and I can't see him for 3 weeks. They rushed him to the hospital that night by aircraft, by helicopter, and he died in the hospital. And I saw
Sorry
his
to hear that.
and I saw his doctor just a week later, and it was the same. He had the same doctor I had, and the doctor said to me, "What did Dave die from?"
He didn't
And
even know.
he didn't know. And I said, he died because they didn't take the time to look what was wrong with him.
Yeah.
And the doctor said, no, no, Frank, you're wrong because he died in the hospital. And I said, no, you're wrong, doc, because that's the second hospital.
Yeah. Not the
Died because
first
the
one.
first one didn't bother to look what was wrong. And he put his, I'm not exaggerating the least, good doctor, good guy. Most of the doctors are in this business because they want to help people, not
Mhm.
because they want they're not looking for the money out of it. They're looking to help people. Anyway, the doctor sat down, put his head in his hands, and damn near cried. And he said, I remember a time, Frank, when I could take care of my patients. They won't let me anymore.
No.
So what I'm saying is what this book is written to do is not just expose the fraud in the middle of the system, but to make the system work as it is. Because I'm convinced it's not going to change. There's too much money, too much power. But fortunately, the laws that protect us, that give us the care, the coverage, and the billing protection that were there for our parents are still there. And if you understand them, you can do what I recently did for my wife. I sat when she emergency situation, goes in the hospital, uh, really critical,
Hmm.
and what was going on was wrong. And so
Yeah.
I sat down with the doctor and I said, let's get this straight. You work for me.
Yeah.
Okay. You're on your license, not the hospital's. And my wife is not leaving here until I understand exactly what's wrong and have a program uh, for treatment where I can look and have confidence we know where we're going.
Hmm. We need diagnostics, we need a plan, and we need some discharge education to be able to get out of here and make sure we don't have to come back and we can get this treated at home, correct?
Yes. And actually, it went over. I'm making it sound adversarial. It went over quite well, actually. what I said, all of a sudden I had doctors listening to me and I had meetings and so forth, and we made the right decisions. And my wife is back and far healthier than we would have expected. She's fine.
Well, good. I'm
It
glad
was
to hear
that
that.
it wasn't what I'd hope people would understand in this podcast. It wasn't my taking an adversarial role. It was my insistence on being able to talk to the doctor.
Being able to talk to the doctor and make sure the job gets done correctly. It's not adversarial. You're just standing up for what you know your rights are when you're in the hospital, when you're receiving this care.
And my take on it was the doctor appreciated my understanding the system
Hmm.
working within it that allowed them to depart from the way they were being pushed, coerced to
Yeah,
treat and
strong
speak.
armed. Yeah,
So he could simply say, hey, this guy knows too much. We need to talk to him.
yeah,
That's my take on it. But it was what happened. I got phone calls, I got following, I got everything I needed. We made major changes. Um, and it the book is aimed at trying to make the system work, to help the doctors, the hospitals, the nurses do their job and avoid the money end of this thing that's torquing it all out of shape.
yeah.
Well, you and I could talk about this for a long time because there is so much within the system that's wrong. Um, the insurance, it's when you, I, I was a problem solver in industry for a long time, general manager, whatever. But what I really traded on was being able to solve problems and
Yeah.
big. And I always found that the first thing you had to do was agree what was wrong and get your language attuned. We really have to be using the same terms. You can't understand coverage unless you can understand how the insurance has twisted the definition of insurance. I'm sorry, of coverage.
Yeah.
If I say I have coverage for an automobile accident, I have coverage.
Yeah.
If I say I have coverage for a new knee in my healthcare plan, that's not true. They may pay for it, but they want coverage. They want two definitions for coverage. When I ask, do I have it? What I'll be told is yes. And then when I need it, they'll be very happy to tell me no.
They
Now,
want to
there's
deny
no
it.
other, yeah, right. Now, there's no other form of insurance in the world that on one hand would say you have it, and then on the other hand say they could deny it.
Yeah, you have it, but also we're not going to give it to you.
That's right. So that they're misusing the term because in any other form of true insurance, it's just not coverage. It's a contractual requirement.
Yeah, because I mean, you entered
Also,
into this contract as two private parties
yeah,
between you and the
insurance company.
insurer, insurance company.
Yeah.
Yeah.
So if you have a dented fender, you can if you have a dented fender, you have every right to go in and say, whoa, whoa, whoa. My fender is dented, and no, you can't tell me I can't fix my fender.
Because I pay you every month or annually for
Exactly. And we can
exactly
argue
this
about how
this
much we
purpose.
spend to fix my fender, but you're going to fix my fender.
Yeah.
You're not going to make me take a pill instead of getting my knee replaced.
Just take some ibuprofen for the rest of your life.
It's
It's over the counter, it's cheaper.
yeah,
So I think this would be a good springboard to get into the what was it, United Healthcare and their algorithm. I know we talked about this briefly in the email. Their algorithm that was denying upwards of like 80% of claims over a 4-year period that it was implemented.
yeah. Look, I think there's always it's dangerous to leap out into unproven ground or undefined ground. I'll say it this way: I like to approach problems from 30,000 feet and look at the total problem rather than get buried in the grass.
Fair enough.
Where attorneys for healthcare companies would like to take you because there's enough gray down there to confuse all of us.
Mm,
But it's pretty obvious that the healthcare industry denies care. As I said, the Supreme Court knew it 35 years ago. And there are people that are really hurt just from the denial of care. And then when you look at the fact that over 50% of the bankruptcies and the family bankruptcies in the United States are a healthcare bill, there's a lot of room for rage out there.
Yeah.
And the insurance company has learned to make money by denying care. Okay?
Because if they're not paying it back out and you're still paying your monthly premiums, then they're going to just bank all of that
They're
by the
going
end
to
of the
bank it.
year.
And even if they just delay it, it makes money.
Yeah.
You look
I
at
mean, if they
big,
delay it until the point where you expire, then they get to save all that money.
oh, and one of the things they will mention is okay, we deny coverage, but you can appeal it, right? Wonderful. I'm in the hospital. I need it. How long can I lay in the bed while the appeal process goes on?
Is
I
it? I
can't.
think sometimes it takes up to 14 days, if I'm not mistaken.
Well, that's the first level. There are multiple levels, and the thing it could drag out forever. But on top, what, 3 days in a hospital is over $30,000, $40,000.
Depending on what level of care you're on, too. If it's ICU, it's going to be even more expensive than that.
Yeah. So they also know that if they delay it, there's a good chance that you simply will the need will expire one way or another. Conditions will change, one thing or another will change. It'll just go away. And even if
Yeah.
it doesn't go away, they'd much rather spend, say, $1,000 6 months from now than $1,000 today. So it works financially in all ways for the insurance company and not for the patient.
It benefits the one-sided giant corporation.
Terribly.
Yeah. Hmm.
So, I'm sure you've been in the middle of a lot of it and seen it. So
Unfortunately.
it's unfortunately, and I would say it this way. I think I mentioned the quote earlier, and I have to give it to Michael Smerconish. I heard it on a TV show. It's not so much what they do, but they've gotten so good at it. And what they're getting good at is denying care for any number of reasons and cutting off the ability to contest it. If you look at what the doctors have done, we talked about the fact if you go in the hospital, as my friend Dave did, and he died in there, there's no feedback loop.
Yeah.
In any other system I've ever known, there's a feedback loop. And we sit at the other end and we go, oh, Dave died. Why? And then you go back through it, not really to get anybody or to hurt anybody or whatever, but to find out what we did wrong so we can correct it and do better the next time. Right?
And there's no feedback loop between the hospital system and the insurance to be able to benefit patient outcomes
Sure. But it's
currently.
gone.
Yeah. It's been, I mean,
Severed
it's
it.
not profitable. If it's not profitable, cut it out.
Well,
Or don't
they
do
don't
it.
want the discussion, right?
Yeah,
They
they don't
want
want to talk about it.
no. They want fewer and fewer doctors covering more and more people, and people are going to fall through the cracks. And that works to some degree legally if you swell the system big enough,
Yeah.
but it doesn't work at the individual doctor basis.
Hmm.
And I'm back to the sense of saying, just wait a minute. Hey, doc, you work for me.
Yeah.
I don't want to say that adversarially, but because I've also said in the book, and I mean this, if a doctor doesn't work for you, if you don't have a good relationship with the doctor, get another doctor.
Yeah. And you have every right to do that. I've seen patients fire doctors that just came to the room because they've not seen that doctor but one time in the past couple days
Oh,
during the rounds for 5 minutes, and they're like, "Well, I don't like you. We don't get along well. I'd like another doctor." And
well,
it's within your patient rights to be able to request that. And there's a
we
whole list of those rights too. I've covered in a prior episode that's kind of lengthy and boring, but you have these rights. And most people, they get a handout when they first come to the hospital, but they never actually get a chance to read through and understand it. You have a right to request bills. You have a right to request a new doctor. You have a right to know who's taking care of you. And I feel like those rights kind of fall through the cracks a lot.
you just said something that's I think terribly important. You have a right to understand the care you're being given.
Hmm.
Okay. And that's all you're asking for. The time to sit with the doctor and understand what they're prescribing, what they think is wrong, and so forth.
Hmm.
In my wife's case, it saved her life. And we did change our doctor. We were in there for what was supposed to have been a heart problem.
Mhm.
It wasn't a heart problem. She was bleeding internally. And the
That's
only
pretty
reason
scary.
that came out was because I met with the doctor and I said, I want them to calculate that they wouldn't take her off the blood medication, blood thinner.
Hmm.
I'm saying, I think she's bleeding to death. You say she thinks she's bleeding to death. Take her off the blood thinner. And they go, well, we don't like to do that. And I'm saying, I'm telling you to do it. I'll accept the risk for her. To make a long story short, uh, we changed doctors because the doctor she had would not sit down and talk to us.
Hmm.
We found a doctor who would, and we talked to that doctor for the better part of an hour early on when you first went there.
That's fantastic. I do like hearing that because normally it's difficult to get providers to spend more than 10, 15 minutes in a room. Oh, sorry. Go ahead.
It's for us, it was a matter of the doctor she had. Literally, the last time we saw him, came into the room, spent 5 minutes on the computer, and then looked at the two of us and said, "I'm confused," which told me he hadn't even looked at the case until he walked in the room.
Hmm.
And he was trying to understand the whole case through what's on a computer screen, and that's insane.
In just a couple minutes too, and just browsing through and looking at the bold print.
And then he said, he said, "I'm very heavily booked. So I'm going to have to ask you to come back in 6 months. And I can't see you before that because I'm booked full." Give me a little credit. I walked out of the room without getting, somewhat upset, but
Yeah.
we got another doctor, and that doctor sat down with us the better part of an hour the first time.
Well, good.
And my wife does not have a heart problem. She had a bleeding problem. We resolved the bleeding problem, and she's back to tennis and swimming and a full life. But the system we were in didn't even want to take the time to figure out what was wrong.
The system's not set up to do that, especially in hospital too. It's efficiency again. How can we see the most people with the least amount of staff in the shortest possible amount of time? That means you got to spend 10 minutes at max in a room. And doctors hate doing that. I don't know any doctor that likes the way that the system and the schedulings are set up when, especially inpatient care, an acute patient or an acute inpatient stays, when you have someone that's got a stroke and you're a neurologist, but you've got 40 strokes to see today in the hospital because you're following all these cases. I can't think of a single doctor in any specialty that likes going in and only being able to spend 5 minutes with a patient to explain what's going on and then not being able to answer questions and then leaving. They don't like it. The patients don't like it. The nurses don't like it. No one likes it. So why is the system still set up to run like this?
Well, I tell you what, we could go on up this for a long, long time because, again, everything we think we know is wrong. Like
Mhm.
just a little one. You're in the hospital, and the nurse comes in and says, "Well, the doctor says you're to be discharged." Okay. Well, there are only two ways you can be discharged. You can discharge yourself.
Which would be against medical advice.
Well, I'm saying, but the doctor's now advising that he's not, well, not advising. The other way is for an order from the doctor for discharge.
Hmm.
Never happens. You're better at that than I am. I mean, why is he going to go on the record of discharging you if you fall down when you go out through the door? It's his liability.
It's happened before.
Okay. But he doesn't do that. He gives you a piece of paper that you then sign discharging yourself and he non objects.
Hmm. And also understanding the discharge instructions, the stuff that the nurses add in at the end.
All
Um,
the bases are covered, but you've discharged yourself.
exactly, exactly. It's hey,
Well,
did you have any questions for me before you go? No. Did I answer any questions you did have? Yeah. Okay, okay, then you're good to go. Um,
there's nothing to stop you from saying, I don't feel quite ready to leave.
hmm I've had that before too, and I've told doctors this patient's not ready to go. They don't feel ready to go, and it's not a great conversation after that with the
It might
doctor.
not be because I could see the financial pressure to get him out the door
Oh, absolutely.
because
I mean, it's
I'm
top-down leadership too. So we have what's called like a house supervisor, which is managing what we call the bed board. We've got so many beds in the hospital. We've got so many beds in the emergency department. We've got these cases holding down here. We need to get patients out so we can get these people in. It's triaging level of care that we learn in nursing school, except in an inpatient setting. Or if you have a natural disaster, let's say a tornado comes through, the people that can go home the safest, we need to get them home so we can get these other patients in that are more acute now.
This is a world that you know more about than I do. Okay. I've stayed at the contractual level and the document level,
Hmm.
but I do have some knowledge. And it came from when I was suing the insurance industry and at least the hospital she was in. But there was a representative in the hospital, and I would bet heavy money they're still there, who represents the insurance company.
Hmm.
And they go over the beds, the patients on a daily basis to determine who should stay and who should go money wise. And when they decide the patient needs to be out, there's someone assigned to get them out,
Hmm.
because now you've turned the corner. The insurance company is not going to pay anymore.
Yeah.
The
At least
patients,
they state they won't pay anymore.
they've said this is over.
Yep.
Okay, we're not going to pay you anymore. And they have that right contractually. And then the only answer for that for the hospital is to get them out.
Yep. Or get
Okay.
them to a subacute rehab.
Okay. Well, if you could transfer the coverage, but
Yeah.
the point is the money now is dictating the problem, and it's the
Yeah.
insurance industry. And so,
It's not the providers, it's not the nurses that are saying, hey, this isn't the way this should go. This dude needs another couple days here. He needs to go to at least 2 weeks of rehab to get his strength back. Insurance can just say, well, we're not paying for that rehab. And it's just like, okay, well, now we have to get him out of here and he's got to go home.
it's a long time ago, but
Yeah.
I don't think it's changed. You still have that insurance person looking at the beds on a daily basis. And I banged, when I say banged heads, I tried to deal with one of those people years ago, and they won't even come in the room.
Hmm.
They never want to touch the patient, because then they have liability. And
Yeah.
I saw an article just the other day that just kind of blew my mind. Somebody was terribly upset because one of the head doctors in a large insurance company had acknowledged that they never look at the medical record when they make a decision of coverage. Why would anybody be surprised? That doctor does not want to be touched, come close to liability.
If I never looked at it, I can't be held liable for it, right?
Exactly.
I
I'm
had
not
no
making
knowledge
it,
of this case.
I am not making it, I'm not making a decision on care. I am solely making a decision on coverage,
Hmm.
divorced from care.
Alleged coverage that we're supposed to have that we've talked
Alleged
about
coverage
that
that you
really
don't
doesn't
really
seem
have.
like healthcare coverage.
Yeah, it's really just payment. Am I going to pay or am I not going to pay?
Yeah.
And since we're having fun with this, think of it this way. There's a big statement of, well, you have a copay or co-insurance or this or that.
Copay, co-insurance, maximum out of pocket, all the fancy terms.
Yeah. Well, I just want to know, I'm a fairly decent mathematician. How do I calculate copay or co-insurance if I can't bill in the first place?
If you can't accurately bill.
If I can't bill at all?
Yeah.
Contracts don't say I can bill a little bit. They say I can't bill anything.
Hmm.
And if I can't bill anything, how do you calculate a copay?
Or the co-insurance or my maximum out of
Co-insurance.
pocket.
The whole thing collapses. It's a house of cards. And that's okay if it worked for us,
Yeah.
population, the general public, the people who are in the hospital, the people who need the care. But it
Yeah.
doesn't. And it's not honest.
It's a big middleman sham.
And all I've tried to do with the book is give somebody the means of making the system as it is work for them instead of the insurance industry. There are letters in the back that you write in order to deal with the healthcare bill. There's a list in the back of all the little things that you should do, like just a simple little thing. The surprise billing that they always talk about makes sense. If you go in, just write a little note. leave it at the desk, that you are not to give me any care that is not in, unless it's in network, unless you have my written approval.
You have
It
to have
should go
consent.
away.
Yeah.
Okay. Now I could fight it. I don't have to do that. And I explain that in the book as well. Let's say a doctor, uh, an anesthesiologist pops up and sends you a direct bill. I'd send it to the hospital. It's their bill. He's a subcontractor.
Yeah.
He
You
works for
never
them.
signed a paperwork saying that you wanted to be billed for anesthesiology.
That's right. But not only that, even if I don't do that, he's a subcontractor of the hospital.
Yeah.
He works under the direction of the hospital. He's their problem.
Hmm.
It's their bill, not mine. And I'd love to debate that in a court of law. Okay. He's a subcontractor. He's only there as long as the hospital allows him to be there, and as long as he performs in accordance with the direction of the head of head of surgery or head of the medical director.
Yeah.
He's a subcontractor by any definition in law. So again, what I would hope people would do is, matter of fact, let me offer this to you. When we're finished here, you send me by email an address, and I'll send you a book. And if you would take the time to read it over the holidays or
I
something
would
like
love
that,
to. I would love to.
and then tell me what you think. And I'm more than open to all the criticism you want to throw my way.
Fair enough.
But if it makes sense to you and we can do something together to help people simply understand how to deal with the existing system and come away whole.
Absolutely. And be able to still put food on their tables at the end of a hospital stay and
Yeah,
acute rehab, getting their prescriptions, whatever it may be.
I've never had a time when a doctor or a nurse hasn't uh, appreciated the fact what I've learned.
Hmm.
One other quick story. My wife was, uh, since she was on blood medication some time back, she developed a nosebleed, which was no small issue, and really taught me what it means to be on
Blood thinners.
blood thinner. Whoa.
Oh,
Yeah.
they're ferocious. They
Yeah.
are ferocious.
Somebody turns on a faucet.
Yep.
Anyway, we did get it resolved, but we had to get a specialist to take out the packing and this and that. So we went to a
Was it
doctor.
the did they use the oh, what is it called? The sinus rocket where they put like the balloon in the nostril
Yeah.
to kind of air it up?
Yeah.
Those things are
So
crazy.
so they had to usually had to get it out. But
Yeah.
you needed somebody with some skill, and not just somebody yanking it out. So anyway, we went to a specialist we had never known before, and I had a copy of the book with me. It was an early copy, but anyway, on our way out, I was doing some of the talk for my wife, so we were at the counter, and I had the book lying there, and across there is the big lie on my healthcare bill, and the nurse picked it up and she looked at it and she gave me the biggest smile in the world. And she said, "We're not supposed to say anything." And then she shook her head as violently, "Yes, yes, yes, yes."
Yeah.
And
Yeah,
she
we
could.
well,
And
that's another thing with the system too, is we
that's no
know how
joke.
broken it is from the
That's no
inside.
joke. We're not supposed to say anything, but yeah, yeah,
Yep.
yeah.
Blink once for yes, twice for no kind of thing.
Yeah. Anyway, I'll be more than happy to send you a book. And I'd love to talk to you anytime you want to talk. And if we can do something collectively to help people, I'm all for it.
I absolutely am too. I think that sounds like a fantastic project to work on with you.
I
And
appreciate it, sir.
I appreciate your time today, Frank. Honestly, it's been very eye-opening. This is everything I wanted and more, except for the part where Zoom cut off the meeting about 30 minutes in. That was the most stressed I've been all week.
Yeah, there you go. But we got back together and it worked fine.
Absolutely. Before we do finish up, there was one other thing I did want to ask you. What do you think the future looks like for this? If we can come together and work on some legislation for the future that makes it work better, or if we can just get together with other providers, like how and who in your brain could start to make this system work a little bit better.
Um, Let me say it this way. The Clean Air Act was a very, very big deal in this country because you had all the powers of industry against it.
Hmm.
Um, and I was really in the middle of that. I mean, I'm blowing my own horn. I really was. I was the sole person who stood up and said, what you're doing is wrong in law. And I was against like Bill Lewis, Morgan Lewis, and Bacchius and people like that. And they were the biggest in the country. And I won that argument because I didn't try to tell people how to do everything else. I just said this point's wrong.
Mm-hmm.
Okay. There are a lot of very smart people in the country. And one of the things we are very good at as a country is when money gets involved, we find a way to solve the problem.
Absolutely.
Okay. What I'm going to advocate here is that we simply alert people to how to deal with these bills, and the system will right itself.
Because once the hospitals start losing money, the hospitals are going to start bucking back against the insurance.
They will push back. And
Mm-hmm.
when the doctors find out there's a problem with their billing, they will push back.
Mm-hmm.
And where the AMA right now simply says, and I can quote them, you know, normally the insurance company will pay for the care, but when they do not, you must absorb the cost.
Mm-hmm.
That'll go away. And so rather than you and say you and me sitting here trying to guess what should be done with healthcare, should it be private, should it be a public system? I think that's a mistake. It's too far down the road.
Mm-hmm.
What we really need is something that jars the system, where we have to take a hard look at what we're doing. We already know we spend far too much money in the system we have.
Yeah.
And too many people are getting hurt. And the real center corner, the central part of that is money. So if we go back and believe what we said earlier, that this country is very good at solving problems when money's involved.
I do believe that.
We'll find a way. And not only that, you and I come across as far more credible if we aren't trying to drive an agenda.
Mm-hmm.
All I'm trying to say is, hey, this is the fact. These are the facts. This is the truth. If you disagree with me, fine, but you're going to have to prove it. These are the facts.
Yep.
Now deal with them. Okay. And I sound like I'm ducking your question, but I don't think I am.
I don't think you are.
What we have to do is bring the system to a point where they have to deal with the truth.
I think there's no better way to do that than making the money interest align in the side of hospitals and patient outcomes. Patients being the center, and the hospitals being the side saying, "Hey, if we're not getting paid, insurance is now the problem."
If we simply help people understand what their rights are
Mm-hmm.
to care, coverage, and billing, the system will right itself.
That
Because
sounds
it
like
will
a.
have to.
Because what?
The system will right itself. It'll correct itself because it will have to. The bills aren't enforceable. They've just hidden it from us.
And they've hidden it very well for what seems like a couple
Oh,
decades.
very, very well.
And that's what happens when you have clever contract lawyers all getting together.
I have never met a person, and I've been at this for a while, who has read their contracts. Now, you might find an attorney who's familiar with one insurance company's contract or this or that. I've read a bunch of them.
Well, you had
similar.
the privilege of having discovery where your lawyers were able to get all of this information compiled for you
Part,
and
I was
with
the
you.
lawyer. You're looking at the lawyer.
Oh,
But
goodness.
I was also knee deep in the Clean Air Act, and
Yeah.
I was a consultant for. I lectured for EPA across the country as to what constitutes compliance with the Clean Air Act.
Mm-hmm.
So I've been told I'm a good attorney. I'm not going to tell you I am, but I've had a lot of experience around the law, and I knew that if these contracts existed, there would be a way to get to them.
Mm-hmm.
And so I used what I knew from the Clean Air Act and environmental law and so forth. You call somebody and they give you a name, and you call somebody else. And about the fourth level down, somebody said, if you show up at 9 o'clock in the morning at the library,
I can get you this.
well, I can get you in. And that's exactly what happened. I'm not sure I had the right to be there, but I got in, and they let me read anything I wanted to read. I just couldn't copy it,
Mm-hmm.
but I could take all the notes I wanted. And I later got copies too. But the interesting thing is in the back of this book, you'll find a contract. And the reason I can print that is because the contracts are very, very similar, but the language changes a little bit. So I can give you a contract in the back of that book that represents the contracts across the country, but no one contract.
Mm-hmm. Because
So
of
they
the
can't
little
come
tweaks
back to
and
me
little
and
details.
argue, that I violated the confidentiality provisions of those contracts. I haven't.
Mm-hmm.
I've written something that's very general, and in general represents those contracts, and they can't cite me for reproducing the general contract,
Yeah.
only specific. So
I
if you
mean,
read the book,
you're
look at the
putting it in
back.
your own words,
Yes,
essentially.
putting their contract in my words, which gives me the structure. And the
Mm-hmm.
thing you really need to look at in a contract is not so much the individual language. Lawyers can turn you in knots with that. I want to see the structure. What are they trying to do with all this language? And when you look at that, the contract's very clear. They, in about 5 different provisions in 5 different ways, give the insurance company the right to not pay whenever they want for whatever reason. However, all of their in-network providers are required by that contract to provide all the care the doctor says you need.
Mm-hmm.
And that doctor's under a license that is accountable to you as the individual. And let me quickly say, if I could go back to my wife's situation that I described, I could handle it today. I couldn't then. But I would say today, excuse me, I'm going to pay for it. And they'd say, no, you can't. And then I say, well, you've got a problem. I'm going to have your license or I'm going to pay for it because you're required by law to provide all the care, provide the care that's needed if there is an offer to pay for it.
Mm-hmm.
So we're going to call the attorney general or you're going to give me the care, and they would give it to me because that's the law.
And that's what you've learned in the meantime out of the tragedy.
And they would force me to sign a piece of paper that you see. I agree to pay whatever, blah, blah.
Yeah.
And then when they sent it, once my wife was fine and they sent me the paper on the bill, I would write across it with a nice red pen. This is a legally unenforceable debt. Don't bother me again. Because you can't sell a house twice.
Mm-hmm.
They have earlier surrendered the right to bill me. So what I signed after that
Is
is
not enforceable.
unenforceable. Yeah.
That's
But
fascinating. I'm
that's
gonna have to digest this information for sure. And I really hope that it reaches a lot of ears and it can hopefully change some people's lives financially. Because I feel like this will be quite a revelation for a lot of people that deal with medical stuff on a regular basis with chronic illnesses, that hopefully it can help them save themselves financially from the debt and the potential looming bankruptcy that seems to be plaguing us with this medical crisis that we're going through. So
that's the focus.
that's the mission.
That's the mission.
That's the mission.
And it's all on the positive side, simply
Mhm.
to help people understand how the system we have works.
And how to make it work for us as consumers of
Yep.
healthcare.
Yep. The very people you treat.
Fantastic. Well, hopefully this helps my patients. Hopefully it helps a lot of people around the country. I just need to get a lot of ears on it now. That's the goal.
Okay.
Alrighty, Frank. Well, is there any other closing points that you wanted to
Oh,
make
we're fine.
before?
Thank you very much. I really appreciate the discussion and the time. And it's nice to talk with somebody who's got some understanding of the system which you have, um, because it just makes for a much better discussion.
Well, good. And again, mine's very focused inside the hospital as far as clinics and stuff. I don't have the most understanding of that, but when it comes to the inpatient care, I've been to a few different travel contracts at different hospitals, and it seems pretty much the same shortfalls exist in every state that I've been to so far.
Interesting. Yes. See, I would see that as very positive because, and I think you'll see it in the book. I recommend that they not, even though the bill from the doctor has the same problems as the bill from the hospital, I'm not going to use what's in this book to short a doctor.
Mm-hmm.
I need that doctor. The
Mm-hmm.
only way I can access healthcare is through that doctor, my doctor.
Yeah.
So I want a personal and friendly relationship, and I'm going to pay him what I owe him.
Mm-hmm.
What I'm concerned about is the big money. Go where the big money is.
Mm-hmm.
That's the hospital. You're talking thousands of dollars, and they can easily, swell into the hundreds of thousands of dollars. I
Oh,
mean,
quickly gets into hundreds of thousands of dollars.
and that's where you get hurt. I
Mm-hmm.
mean, we can all come up with a $30 copay or this or that. That's not that's not where you want to go.
Yeah.
That's
Want
not
to
how
go
you
where the $250,000 6-day ICU admission is.
exactly. And even somebody that's working for minimum wages suddenly gets a $30,000 bill.
That's just wrecked their life.
That, that, yeah, that could destroy their life.
Mm-hmm.
Prevent the kids from going to school. I mean, prevent all kinds of issues.
Prevent them from even feeding their kids nutritious foods that'll help them get forward in education, get a better education, go to college.
So where you're most knowledgeable is exactly where the financial problem is.
Mm-hmm.
Because most hospitals are no longer community service hospitals. They're part of a large shell organization.
Mm-hmm. Private interest firms
Yeah, yeah.
or private equity.
Private equity firms,
Yeah, they're PE firms is what's
with
buying
with
up
the
most of the hospitals.
with the mammoth glass atriums and this and
Mm-hmm.
that. Uh, there's a Stephen Brill wrote an article, and I had the same experience he had. His was in Texas with the Texas Medical Association, 13 acres of the most expensive construction you can imagine.
Mm-hmm.
If you go into Philadelphia, I was in there for a conference, and you go into the center of Philadelphia and see the Penn Medicine setup. And I mean,
What medicine setup? Sorry.
Penn Medicine.
Penn Medicine? Oh,
And
Pennsylvania State.
yeah, well, it's Pennsylvania, and the name of it is Penn Medicine, PENN Medicine,
Mm-hmm.
and they are huge, just like you have down at the Texas Medical Center.
Yeah.
It just stretches for blocks and blocks. And matter of fact, we went to the conference, and it took us something like an hour and a half to find the conference room.
Well, yeah, because you've got 1,400 rooms in
With
that
blocks
building.
and blocks, yeah.
Yeah. There is I knew a nurse that did travel and do a contract in one of those hospitals in Texas. And she said the amount of time it took her to learn that hospital was pretty much the entire 3 month like assignment of her contract. Like she had one route to get to the cafeteria and back up to her unit she was at, and then that was it. Like to find any bathrooms,
Oh,
any other entrances was almost impossible. I mean, you have these um these hospitals that are hundreds of millions of dollars that expand over several acres of campus.
oh yeah.
And I'm
And the
one part of me
number
is like, that's really nice that we can do that, but also the other part of me is like, why do we need such an expensive campus to provide healthcare? Like, you don't need all those odds and ends. You don't need an airplane hanging in the atrium with the fountain. Like, you don't need that. You need patient care.
you need patient care, and quite honestly, I'm going to come back to what I said earlier. If the billing becomes a problem and is not enforceable, the system will find an answer because it
Absolutely.
has to. And whether that's efficiency and fewer people or people focused on actually delivering care or whatever, they'll find an answer because we're good at it. We really are good at it. But as long as they can bury the truth and bill for things that never show up or ignore their own contracts,
Hmm.
uh, we're never going to see a solution. And we're going to have an awful lot of people hurt because there is no good solution. And the big problem with a lot of it is people don't even look at healthcare until they need it.
Yeah. And then once you need it, then you find out how
Yeah, and you trust your insurance
like,
company.
you trust your insurance company, even though you probably shouldn't, because they're going to require pre-authorization and everything else under the sun and still try to deny you what they said they would give you. And
Mhm.
that's what you paid into for the past 15 years. And now that you need it, you don't have it.
You don't have it. And the truth is, what you don't realize is you don't have anything, nothing enforceable,
Hmm.
which gets in. It is some interesting law because you do have third party rights in these contracts, but you're not going to find any court very interested in litigating that because it creates too many issues, too many waves.
Yeah.
When you read the book, you'll find some interesting situations where, excuse me, where he described where the courts have turned themselves in knots to avoid deciding issues.
Really?
Oh, in Pennsylvania, the law specifically states that insurance companies have to provide 30 days of alcohol rehabilitation.
Mm-hmm.
And the determination for who needs it can only be made by a licensed doctor.
Yeah.
The insurance industry refuted that and claimed that they had the right to make those decisions. The law is very specific. The Supreme Court of Pennsylvania took 6 years to come down with a decision on that simple point. And it stated basically that while the law is very clear, the acts of the insurance company are really not well defined, and therefore no decisions required.
So
And
they couldn't, 6 years and they still couldn't come to a decision on it. They said no decisions required.
oh no, they just walked away.
Oh my goodness. Oh.
Well, but that's what you're into.
Yeah.
What people are into with bills. The system is so set up to enforce the bills and the entire system that if you make the mistake of getting caught in it, in its gears, it will grind you up. One of the largest alcohol rehabilitation facilities here is the Caron Foundation,
Mm-hmm.
very well known nationally. And I did happen to get to know some years back, but anyway, the director of the Caron Foundation, and he told me out of school that they had tried for years to find a way to allow people to pay for their own care, their own alcohol rehabilitation. They couldn't.
They couldn't find a way to let people pay for their own care
Not
outside
around the insurance company, because as I mentioned, the insurance company bars all payment. And so when they deny coverage for that, even though it's against the law, they bar all payment. And even though this vice president of legal tried for 10 years, he said, to find some way to let these patients pay for their own care,
couldn't find it.
no, because the contract doesn't allow it. And the last thing the insurance industry wants is to have these contracts pulled up and analyzed.
Yeah, they'd rather not have that come to light.
No, no, no. So they're coming after you, and you know that.
And then your butt's on the line.
Yeah, right. You're in business.
As an owner as a business owner, as a medical provider, your butt's going to be on the line for that when they come for you.
I don't know what the number is anymore, but when I was more active in this thing, the number that used to be kicked around was something like 70% of all income comes out for the healthcare industry, the hospitals and so forth, comes out of the insurance industry. And I'll bet it's even bigger today. But
70% was coming from the insurance companies.
yeah, so I mean they are the bank for the healthcare industry. So if the bank stops delivering money,
the system breaks.
and everybody, all these contracts allow the insurance company to terminate you at will. So if you're a doctor or a hospital,
you're basically an at-will employee of someone else that's not in practice.
And you get in a tiff with the insurance industry, a big one, they can terminate you, bang, and you can't afford it. Now, it's better today than it was some years back because the hospitals have become jointures. They're no longer just community hospitals.
Mm.
It's still an awful lot of pressure when you consider how much money, any one of the major hospitals gets from an insurance company. Because remember, insurance locally is a monopoly.
Mm-hmm.
If you look at the area I'm in, Penn Medicine's the biggest hospital, and Blue Cross
Blue Shield.
It's Blue Cross Blue Shield. I've forgotten anyway. It's a Blue Cross Blue Shield.
Anthem. The other name for it.
Damn it.
Cigna.
No, but it's the same thing. It's one of the blue. It's one of the blues.
Okay.
But I mean, it owns the whole territory.
Mm-hmm.
So when you look at Penn Medicine, and they're the biggest hospital and caregiver because they own tons of doctors and satellite facilities, the bulk of their income comes out of
Comes from that one insurance
So
company.
they get in a tiff in a fight. The money always wins.
Of course, yeah, because they threaten to dry it up.
Mean, that's not that's not a healthcare problem. That's a problem across the country. That's the same thing for every industry.
Yeah. Hmm. Ah, it's just,
We have a unique opportunity here. I'm going to sell on you. I always tell people when I sell, this issue is so real that and it affects so many people that we don't have to sell the issue. We just have to disclose it.
and then
We
let
don't have to
the
win the argument. We just have to lay the facts on the table. And it is what I would argue the only thing I can possibly see that can bring reform and change to the system
hmm.
because it limits the flow of money. And not because we did it, but because they did it to themselves. And we're doing nothing but disclosing what they've done.
You've laid out a lot of knowledge for me to absorb today, and for anyone that listens to my podcast to absorb. But if we get enough ears on it over the next few years, I feel like there can be some meaningful changes that do come from it that help out a tremendous amount of people.
This is not an issue that we have to win today. It's just an issue we have to win over time.
Exactly. Exactly. And like you said, with 6 years to get any closure from your case personally, it takes years. It's a uphill battle. It's Atlas pushing the stone up the hill. But one day you're gonna reach the top of that hill as long as you keep fighting. It's got to keep pushing the boulder every day.
That's the I got to really this thing goes on and on. I wound up on Veterans Day making a presentation to a whole bunch of kids at school, and one of the nicest things they sent me a long letter and thanking me for what I had done and this and that. One of the nicest things they said was that I gave them an understanding of how important it is to know where you want to go in life
Hmm.
and then work to achieve it. Uh, and I think that's, if I leave anything as a message, that's it. You really have to know what you want in life, what's right. And I really believe there is a right, and then work for it. There is no such thing as being guaranteed to win it or guaranteed to have the right answer. But this system we have in the country it allows us to work for the right, to work for justice. The courts don't give you justice. That's a mistake. They give you the right to go in and argue for it.
And that's what sets us apart from the rest of the world.
Mm-hmm. And people keep looking for some magic answer. There's nothing in healthcare that's going to be magic because it's
Mhm.
expensive and it gets more expensive by the year just because of technology,
Mhm.
better treatments and systems. But on the other hand, there is a sense, there is a basis of truth that we can hold the industry to. And what I've tried to do is accomplish that through the book and this podcast.
I think you've done a great job of accomplishing it. We've got a lot of information to a lot of ears. So we'll have to cover all of it. I'm gonna break this down into a digestible
Pieces.
format that goes through, and then advertise the heck out of it.
And if
Try
you
to get
have
as many
any,
people onto it as possible.
and again, don't please send me your address and I'll get you a book off and then you can spend your leisure hours.
Oh, absolutely. I will
It's an
read
easy.
through that sucker in a couple weeks.
Okay.
But
Thank you very, very much. I really enjoyed this.
absolutely, I really enjoyed it too. I'm gonna go ahead and if you made it this far in the video, I'd like to thank you for checking out this week's episode of the Mercenary Podcast. If you like this video, be sure to drop a like down below, so helps the algorithm pick it up. Also, if you enjoy the content, be sure to subscribe so you never miss an upload. Thank you, and I'll catch you guys in the next one.